Hello and welcome to the second lecture for your Intro to Anesthesiology rotation. Last time we talked about pre-op assessment, where we learned how to not cook our patients, and that I have that dog in me. Today we will speak about the next phase of anesthesia, intra-op. There's a lot to talk about, so I'll be breaking this into several parts. So here's part 1, induction. Let's talk about it. Learning objectives. So we will go over what induction is. We will then go over common induction agents for general anesthesia and sedations. And then we'll give you some scenarios in which you would choose certain meds over others. So, what is induction? The goals of anesthetic induction is to decrease sensation and alter and sometimes remove consciousness from our patients entirely. I say sometimes because certain procedures require minimal sedation while others require general anesthesia, and that's where a patient is completely unconscious and unarousable. For the rest of this lecture, assume that I'm talking about general anesthesia. For general anesthesia, we provide amnesia, so they don't remember being cut open and paralyzed, analgesia, because your body still responds involuntarily to pain. So is your brain processing that you're in pain? No. But pain receptors still transmit signals that cause sympathetic activation, resulting in hypertension and tachycardia, as it would in the awake state. The medications that we use for induction, as you will see, are procedure and patient dependent. While you can induce anesthesia using our anesthetic gases, today we will only discuss IV agents. And what you need for that is, you guessed it, an IV. The IV agents we use work by rapidly producing unconsciousness by CNS depression. These medications enter circulation and cross the blood-brain barrier to act on central receptors. The more lipophilic the drug, the easier passage and quicker induction. We see the same effect when it comes to increasing age or head trauma. The blood-brain barrier permeability increases whether naturally or from trauma, leading to faster inductions that require lower doses. So induction medications put you to sleep. You can't see me right now, but I'm doing air quotes when I say sleep, because general anesthesia isn't sleep, but it does have some similarities. I'm not going to be that guy right now, but just know that it's different. I got a little off track, but so induction medications put you to sleep, but we also give certain adjuncts to the induction agents. We will talk about some of the common ones. So lidocaine, it works by blocking sodium channels on nerves which decrease action potential propagation. That produces decreased sensation and decreased sympathetic responses to pain. We give this for several reasons. 1, to decrease pain from other medications we use for induction. They can sometimes cause a burning sensation in the veins, and lidocaine may possibly numb the veins to this effect. 2 is when we intubate patients. We do this by sticking a laryngoscope in their larynx and practically hanging them like a meat hook to get the endotracheal tube in. If you couldn't tell by my description of the process, it hurts, and it's not uncommon for someone's systolic blood pressure to be in the 200s because of this. So we can use lidocaine to blunt the laryngoscopy effect on someone's blood pressure or hemodynamics. It could also help us prevent bronchospasm during our airway manipulation. Some potential downsides and adverse reactions to lidocaine is its metallic taste in the mouth when given IV, and tinnitus, both of which are neurologic manifestations. And we also have the dreaded LAST, which stands for local anesthetic systemic toxicity. It's a nightmare manifestation of CNS and cardiac toxicity that can be fatal or require ECMO. The doses we give are 1 milligram per kilogram, which is safe to avoid that complication. Our next adjunct is fentanyl, which has a really bad rap because of the opioid crisis. When not abused, though, it's a very handy drug. So fentanyl works as a short-acting mu-opioid receptor agonist at both the brain and the spinal cord. We use this for the same reason as lidocaine, to blunt the sympathetic response to laryngoscopy. Both lidocaine and fentanyl act as CNS depressants as well, which thereby makes it easier for us to put patients to sleep with our main induction agent. The main agents that we will talk about all have unwanted side effects, so these adjuncts allow us to use less of them to help prevent those. The induction doses we typically give are in the 1 to 2 microgram per kilogram range. In practice, it's usually about 50 to 100 micrograms that they get. The side effects that you're familiar with are respiratory depression, just like other opioids. Rigid chest syndrome and bradycardia are typically seen at much higher doses than we give for induction generally. Now we're finally done with adjuncts. Let's talk about the big three. And you actually already know it. It's Drake, J. Cole, and K-Dot. But Drake, after the Super Bowl, is kind of not in this anymore. So, K-Dot's the best. Lecture over. Okay, so the anesthesia big three, though not as exciting or as important as rap beefs, there's a lot of similarities as there's debate as to which one is best and when. So we have propofol, etomidate, and ketamine. There are various other things you could use to induce, like thiopental, Versed, and others, but these are by far the most common. So today we're going to yap about each one, but in short, there's no single best agent for every case. A decision is made for each case for what will be best, and if you do the same thing every single time, somebody will get hurt. Let's talk about propofol, the anesthesiologist's favorite drug. This is the most common induction agent that you'll see used, and every patient either calls it by its wrong name, like propanol, or they call it that Michael Jackson drug. And yes, it does get old, but we stay professional though. Propofol induces rapid loss of consciousness and amnesia via GABA A receptor agonism. We call that GABA is an inhibitory receptor that results in CNS depression. We use propofol because it gives us a rapid and smooth recovery, and it has a lower incidence of nausea and vomiting on emergence than other options. Doses that we give adults are around 2 milligrams per kilogram if they're healthy, and it's less, around 1 to 1.5 milligrams per kilogram in the elderly, and that's just because of their physiological changes that occur with aging. I want to point out that pediatric patients need higher weight-based doses of propofol, and this is due to children having a larger volume of distribution. For example, in infants, their total body water might be 75 to 80% of their weight, compared to 60% in an average adult. Their total body water content decreases the plasma concentration of drugs, making them require more. They also have higher metabolic rates, leading to them clearing medications quicker. Some potential downsides to propofol include hypotension. It can also cause respiratory depression and apnea at induction doses. Propofol is also notorious for causing pain on injection, and from personal experience, I can say that it feels like glass. Propofol has some physiologic effects as well. On the cardiovascular system, propofol ends up decreasing myocardial contractility. It also decreases SVR via direct vasodilation. These effects are typically self-limited, but in the unstable patient could be significant. Respiratory-wise, propofol ends up decreasing your respiratory drive, leading to apnea. It also decreases any airway reflexes, which could put you at an aspiration risk. Now let's move on to etomidate. Etomidate is another GABA A agonist that causes CNS depression. It also increases the chloride channel output caused by this receptor activation. A good way to remember what drugs work on GABA A versus GABA B, because it can get confusing, is to when in doubt, just guess GABA A, because more drugs work on that. Or you could think GABA A for anesthesia. So propofol, etomidate, and benzodiazepines. And GABA B for baclofen. You're welcome. Back to etomidate. Some of the adverse effects of etomidate are that it's nauseating and can be more painful than propofol in the veins. Etomidate also causes adrenal suppression that ranges from clinically insignificant in healthy patients, but in the critically ill, especially septic patients, they can see a potential increase in mortality from its use. Studies have shown that cortisol levels can be decreased for up to 72 hours from just a single dose. One of the benefits of etomidate is that it's more cardiac stable than propofol, as heart rate and cardiac output are typically maintained. There is also some vasodilation that may result in lowering the mean arterial pressure, though. And same as propofol, it does decrease respiratory drive, but you will tend to see less apnea with etomidate. Alright, now on to number 3, ketamine. Ketamine is different from the others because instead of a full-blown loss of consciousness, it's more of a dissociative and cataleptic state. So you're pretty much as high as a kite. Ketamine doesn't work on GABA. Instead, it antagonizes NMDA receptors in the brain and spinal cord. Recall that NMDA receptors are excitatory pathways, with glutamate and glycine as their neurotransmitters. With ketamine blocking this receptor, you get a depressant effect then. There are different doses for induction of anesthesia, and what we call subhypnotic doses for acute pain treatment, which we will go deeper into. Some of the unwanted side effects of ketamine include emergence delirium, which is pretty common. Recall that ketamine is a phencyclidine derivative. That means that it's similar to PCP, so some people literally be tripping after ketamine. And we can try to prevent this by giving midazolam or dexmedetomidine, in which studies show the number needed to treat is about 6. So an 18% incidence of emergence delirium with ketamine without pretreatment. So this can result in agitation when patients awaken, and hallucinations are pretty common as well. When I was in residency, we had an acute pain service where we routinely put patients on ketamine infusions for their post-op pain. And when I would round on some of them the next morning, one of my first questions would be, have you had any bad hallucinations or weird dreams? Most patients would have no reaction, and some people would be like, yeah, I hate this medication, turn it off, please. Other people might tell me, yeah, I've been seeing some spiders crawl up the wall, man, but it doesn't really bother me that much. My pain's been well controlled. And for those patients, we just left it running because they were still chilling, and seeing whatever minor hallucination they had didn't bother them. For me, when I had it, for surgery, not for fun, I just had weird dreams that night when I went to bed, but otherwise I was chill. So, all this to say, because of this, it makes sense to avoid ketamine in the elderly and people with psychotic disorders. How old? It really depends, risk versus benefits. Remember that you can get delirium from not having good pain control, as well as from polypharmacy. The people with PTSD and psychotic disorders, it's a given that they would be at high risk of negative reactions, but they aren't completely disqualified. I have a discussion with every patient that I intend to give ketamine for pain control. And I say this medication might help your pain a lot, but it may give you weird dreams or hallucinations later, but it also might not. So that was a lot about delirium. There's several other adverse reactions to ketamine, like increased salivation, but let's move on to the analgesic properties. So how does ketamine help with pain? Excitation or activation of NMDA is another way that pain signals propagate through the nervous system. So ketamine blocking those signals ends up providing significant analgesia as well. This property becomes extremely useful as an opioid-sparing mode of pain management. You will hear the term at some point, multimodal analgesia, or MMA for short. Not mixed martial arts, though you would benefit from pain control if you partook in that. But the idea behind MMA is to provide superior analgesia than opioid monotherapy. Opioids, for the most part, only act on opioid receptors. By targeting multiple pain pathways, we can achieve greater analgesic effect than we can with opioids alone. So what pathways am I talking about? For instance, Tylenol and NSAIDs, they act on cyclooxygenase enzymes for pain. Ketamine and certain opioids like methadone and dextromethorphan also have NMDA receptor antagonism. Local anesthetics like lidocaine for nerve blocks numb you by blocking sodium channels. Now don't get me wrong, a lot of these aren't as potent as opioids, but for instance, say your pain is 10 out of 10, you can only give so much opioids for pain before you stop breathing completely. And nobody wants to stay on these long term as well. But think about if we can use oxycodone to bring that 10 out of 10 pain to a 7.5. And then we give you Tylenol, and that makes it, say, a 7.0. Add ibuprofen and get it lowered to 6.5. A lidocaine patch, and so on. Those are just examples. The pain scores I'm giving are just subjective, but you get the gist. Consider your patients that struggle with opioid abuse too. They're going to be extremely tolerant to IV opioids, and pain control will always be a challenge for them. Hitting different receptors that they aren't accustomed to on top of opioid therapy is probably their best shot. Some patients and providers will scoff at Tylenol and say it doesn't work. This is just a side note, but you heard it from me first. They're wrong. Max out all your patients on daily Tylenol. Max out all your patients' daily Tylenol dose, always. They may still have severe pain, but that just means you need to give them stuff on top of it. Ask me, I'll show you the studies. All of this is important for every single specialty because you will come across pain management in your residency. But sorry about that, back to ketamine. So we spoke about the mechanism and its use in pain control, but let's talk about the physiologic effects. Ketamine has an indirect sympathomimetic effect on the cardiovascular system. So you'll see heart rate, mean arterial pressure, and cardiac output increase typically after induction. It does this by stimulating release of endogenous norepinephrine and epinephrine and also inhibiting their reuptake. But what happens when you're out of norepinephrine and epinephrine to release? Prolonged sepsis and critical illness puts you in a catecholamine-depleted state from the prolonged stress. If you give ketamine in this situation, you have the potential to have a paradoxical effect and become hypotensive from negative enotropy and vasodilation. On the pulmonary system, ketamine is unique in that you maintain spontaneous respirations, so apnea is pretty uncommon. You still cough and respond with airway reflexes. It's a bronchodilator, as is propofol. I forgot to mention that earlier. And I did already mention the increased salivation that you may have with ketamine. Okay, so that took a minute, but that concludes the big three agents. Now let's talk about which ones to pick in certain scenarios. So when do we pick propofol? For routine cases in healthy patients, definitely. Remember, we want that smooth induction and wake up. We use these in most of our quicker procedures too, in sedations like EGDs and colonoscopies. These patients have a 10-minute procedure and go home, so you don't want to blast them with ketamine and have them bugging out for hours later. Now, etomidate, most people reach for these in unstable patients, so think traumas, hemorrhages, and cardiac cases like coronary bypasses. It's also common to see its use in severe valvular diseases like aortic stenosis. Remember to consider avoiding this in patients at risk for adrenal insufficiency, particularly in sepsis. And then we have ketamine, again useful for unstable patients. There's a potential mortality benefit in sepsis over etomidate, and remember that NMDA antagonism is great for pain management. You want to consider avoiding this in catecholamine-depleted states, and think about ACS syndromes, acute coronary syndromes, because the tachycardia and increase in blood pressure also increases myocardial O2 consumption, making coronary ischemia worse. Also, remember to possibly avoid this in patients at risk of emergent delirium. Please just recognize that there's many ways to induce anesthesia. You can do half propofol, half etomidate, or ketamine. I've done that before. Every anesthesiologist has their go-tos and what they're comfortable with. As long as you're thoughtful and take a case-by-case approach, I'll back you. Sometimes. Now let's do the real big three comparison. For me, Loverboy, Aubrey here, he would be etomidate. Lots of papers are coming out about the downsides of it, but it's still a great drug that does its job, and he can still rap, and a lot of bad things are coming out about him. Now, J. Cole, he'd be propofol, all reliable, inconstant, everybody likes him. And lastly, K-Dot, my favorite. It's appropriate that he's ketamine. He and ketamine are not like the others, pun intended. Different mechanism and pain control. Kendrick's dope, and ketamine's literally dope that's sold on the street. All right, if you're still watching it, thank you. We did it. Next time we're going to talk about muscle relaxants, and the lecture after that is finally airway management, the meat and potatoes. So, see you next time.